Dear students, very good evening. Is audio video fine? Kindly update in the chat box. Is audio video fine? Can we start the session? All the students, kindly update in the chat box. Is audio video fine? Can we start with the session? Very good evening, Dr. Parath. Very good evening. Let us start with the session. Are you comfortable with the audio video fine? Very good evening, everyone. Let us start with the session. I will be trying my best. In the next 1.5 hours, we will be trying to complete the whole otology, the whole concepts of otology, whatever is important for ear. Is it audio video fine? Can you update? Can you tell me, is audio video fine? Very good evening. Just give me 1 minute. Is audio video fine? Yes, beta, we have refreshed everything. Now, can you tell, is audio video fine now? Is any background noise? Everything fine on the other side? Can we start with the session? Clear. So, let us start. I am showing you the first slide. Every student should revert back. The first slide I am showing you. Can you make before starting this quiz? Again, integrated learning is a need of hour, but we people are doing a platform of DAMS. We are teaching each and every concept in an integrated way. The first MCQ in front of you. The first query. The parents comes to me with this newborn with having a ear discharge, from a small narrow opening in front of ear, beta. In front of ear. Anyone? What is this diagnosis? Very good. Very nice response in the chat box. What is this diagnosis? A newborn with discharge in front of tragus. The first MCQ which I am asking you, the first MCQ which I will be asking you, yes, everybody should reply. This is pre-auricular sinus, and if this is pre-auricular sinus, every student should reply. It is in front of. Yes. Next query, next MCQ, next question is in front of tragus. If it is in front of tragus, this is your tragus. So which brachial arch is involved? The first question: which brachial arch? Yes. Which brachial arch? Tragus develops from first brachial arch. It means congenital abnormality of first brachial arch. Very simple, very nice response coming in the chat box. Is the first brachial arch is involved? Can you tell me now? You are going for INICT examination. Now the examiner is asking you the next query on the same image. Can you reply which hillocks are involved? First hillock, second hillock, third, or all of the above? I will be going for all of the above. All of the hillocks. Which hillocks? Number 1, number 2, number 3, which is coming from first brachial arch. Always remember pre-auricular sinus. So arch is your first arch, but as for hillocks, very good. Dr. Shreya is all hillocks. First, second, third. So what is the concept behind this question? The 3 hillocks coming from the first brachial arch, while the remaining 3, number 4, 5, 6 is coming from the second brachial arch. Next question on the same slide. Everybody should reply. Beta, at what age you should do the surgery of pinna? At what age a pinna achieve adult configuration or adult size? 2 queries. Yes, important for NEET MCQs. Upcoming NEET examination, they can either ask you congenital size, congenital configuration, achieve the adult configuration by 20th week. Adult configuration by 20th week. But if they ask you the adult size is by 6 years. Very nice. Everybody is responding. Excellent, beta. Excellent. It is not before 5 years, beta. Dr. Pandey, it is not before 5 years, it is 6 years, and congenital is it achieved the adult configuration by 20th week of intrauterine life. These are the important points. Clear? Let us enter into the next segment. Yes, very important point. I want everyone on this platform, let us revise the whole inner ear. Let us revise the whole inner ear with the help of this image. Everybody should reply. What is one? What is number one? Absolutely yes, is cochlear. Number one. What is number one? Everybody should reply. What is this one? This number one is cochlear. What is number two? Number two is a nerve coming from cochlear. You are a DAMS student. I'm beginning from the anatomy. I will be taking into the physio. So finally, we'll end up in the patho segment of ear otology, integrated learning. So we are starting from the beginning. Number one is cochlear. Very good. What is number two? Where is my arrow now? Everyone, let us spend 5 minutes on this image. Let us revise the whole inner ear in a nice way. What is number two? Can you tell me what is number two? Number two is your cochlear nerve, beta. Not vestibular. Absolutely no. Is your eighth nerve. Better answer. Cochlear nerve. This cochlear nerve, and this, if the number two is your cochlear nerve, number three will be the vestibular nerve, obviously, and they will combine to form your eighth nerve. So beta, if you have all the three options in the MCQ, I will be going for cochlear nerve. It is cochlear nerve. And number three is your vestibular nerve. Vestibular nerve. Now I take you to my dissection hall. I remove the cochlea for you. I remove the whole cochlea for you. I remove number one for you. Can you tell me if number one is your cochlea, what is number 4, 5 and 6? 4, 5 and 6. 4 is the lower part of cochlea. Can you tell me what is number 4? Number 4 will be scala tympana. This will be scala tympana. If number 4 is scala tympana, everybody should reply in the chat box, beta. Very less response coming. Everybody should reply. What is number 6? Number 6 will be scala vestibula. Absolutely yes. And 5. What is 5? Scala media, cochlear duct. Scala media. What is the other name of scala media? But I am trying my best to give you all the expected MCQ for upcoming NEET examination. Clear? So number 4 is scala tympana, number 6 is scala vestibula, number 5 is cochlear duct, scala media, and if number 6 is scala vestibula, can you comment on what is number 7? Anyone? Number 7 is a partition which is between scala vestibula and scala media. I will call it as Risner's membrane, because number 8, what is number 8? Is your basilar membrane. Basilar membrane. Dr. Deepak, now everything is fine, beta. There is no background noise. I think everybody is enjoying. Number 7 is your Risner's membrane. Number 8 is your basilar membrane. Number 8 is your basilar membrane. Number 8 is your basilar membrane. Coming on 9, what is 9? 9 are the semicircular canal visible. 3 canals are visible to me. Yes, 3 canals are there. This is superior canal. This is your superior canal. With this quiz, I am trying my best to revise the whole year with you. This is your 9th nerve, semicircular canal, superior, posterior, and horizontal. Absolutely. If number 9 is your semicircular canal, what is number 10? Everybody should reply. Very good, very nice response coming in the chat box. What is number 10? 10 will be the duct from the semicircular canal. It is semicircular canal duct. Semicircular canal duct. Beta, one MCQ expected from this segment. Please focus nicely. What is number 11? Anybody? I am magnifying for you. Yes, beta. What is number 11? Sir, 11 को देख के मुझे लगता है इसे dilated part. हाँ जी, इसको देख के ऐसा लग रहा है इसे dilated part of semicircular canal. Why dilated? Why God has dilated this area? I'm not asking the name. Name everybody knows is known as ampulla. Number 11 is your ampulla. But why God has dilated this area? बेटा भगवान ने ये area क्यों dilate किया? Because God want to put a sensory organ. God want to place a sensory organ. Which one? Which is sensory organ? Sensory organ of semicircular canal is crista cupella. So crista cupella will be there in the number 11. I think you are getting my concepts. Number 11 is dilated. Why dilated? Because God want to place a Sensory organ. What is sensory organ? Sensory organ is crista, cupula. Crista or cupula. Absolutely yes. If number 11 is the ampullated area, ampulla is a dilated area of semicircular canal. What is number 12 and 13? Now, my student who have attended my lecture, who have revised my notes 3-4 times, he will say, sir, all the canals are opening in the number 12. It means one thing is damn sure. Number 12 is your utricle. Number 12 is your utricle. Number 13 is your sacule. Because I am expecting one-liner in the upcoming NEET examination. Which one-liner? Semicircular canal open in the posterior superior part of utricle. What is utricle? Number 12. Number 12 is your utricle. Anybody who can tell me what is number 14? 1-4, last number. Number 14 is your, yes, anybody who can tell me is facing which window? Will be facing which part of the middle ear? Will be facing your round window. Will be facing your round window. Focus your eyes on the board, beta. This image we can revise the whole ear in a nice way. Inner ear in a nice way. Number 1, cochlea. Number 2, cochlear nerve. Number 3, vestibular nerve. Number 4, scala tympani. Number 5, scala media. Number 6, scala vestibuli. If number 6 is scala vestibuli, number 7 will be Risner's membrane. Number 8 will be basilar membrane. Number 9 will be semicircular canal. Number 10 will be semicircular canal duct. What is 11? Ampullated. Why? God want to place a sensory organ. Always remember keyword sensory organ in dilated part. In ampulla, not in non-dilated part. Anybody who can tell me the importance of non-dilated part? What importance for MCQs? Non-dilated part. Anybody who can tell me which MCQ? If you are the examiner, beta, behave. If you are a DAMS student, behave like an examiner. Okay? If you are there to format an MCQ, which MCQ will format on the non-dilated? Dilated, we can make the ampulla. Non-dilated. Of non-dilated. Everybody close your eyes. Just revise the notes again. Yes, anybody who can comment a MCQ. Can you make a beta? In this quiz, I am not asking the answer. I am asking you, I am giving you opportunity to make a MCQ on non-dilated end. Fill up the blank. Non-dilated end of superior canal, posterior canal. Superior canal, posterior canal. Combine to form a common opening. Common opening. Am I understandable? So non-dilated end of the superior and posterior, they combine to form a common opening. Absolutely, Dr. Nitin, excellent, is known as Crest commune. Therefore, is known as Crest commune. Therefore, not angular balance. Dr. Namika, not angular balance. It is Crest commune. Crest commune, superior, expected MCQ, and posterior canal combined. Which part? Dilated, non-dilated. So non-dilated part. Non-dilated part. Therefore, semicircular canal open into utricle with how many openings? So I am expecting 6 openings because 3 canal. But God has gifted 5 openings because superior and posterior they combine to form a one common opening. Very nice response coming in the chat box. Excellent. Coming on the next MCQ. I am showing you a slide. I am showing you a slide. Can you comment on X and Y? What is X and Y? What is this? This is a nerve supply of external auditory canal. Yes, is a nerve supply of external auditory canal. Examiner is giving you a clue. Okay, this is 7th nerve. This is 10th nerve. If this is 7th nerve, this is 10th nerve. What will be the X? X will be, this will be anterior superior part. What is the X? X will be here. Anybody? Any student? 5th nerve. Very good. Very nice response in the chat box. Excellent, beta. I'm loving response you people are giving. Is here 5th nerve. Is here trigeminal 5th nerve. Therefore, patient may have referred otalgia, trigeminal neuralgia. Number Y. What is Y? Y will be C3 fibers. This will be your C3 fibers. So just remember this slide is very important for upcoming NEET examination, or even in INICT they can ask you what is the importance of this area. If I am your examiner, I will highlight this area. What is the importance of this segment? Yes. What is the importance of this segment? What is the importance of this segment? Any student? Patient complaining of loss of sensation in the posterior superior part of the canal. Which palsy? It's a facial palsy, Bell's palsy. There is a loss of sensation in the posterior superior part. What we call it as, we use a word, Hesselberger sign. Very good. Excellent. Is known as Hesselberger sign. Don't confuse with the Henbert sign. What is Henbert sign? Anybody who can reply? Hesselberger sign is a loss of sensation in the posterior superior part of the canal. While what is your Henbert sign? Henbert sign is here false positive fistula test. False positive fistula test. False positive fistula test. Henbert sign. Don't confuse with the Hesselberger sign. Facial palsy. Expected MCQ. Out of these two, they will pick one MCQ for upcoming NEET examination. Dr. Nandi, excellent is a false positive, false positive, false positive, false positive fistula test. Clear? Coming on the next one, next point. Yes, this is a point which I want to highlight for your upcoming INICT examination. Beta. Any student who can tell me this MCQ on INICT examination, what I am showing you Prusek space. NEET people will ask you, what is the importance of Prusek space? Importance of Prusek space, most common site. Everybody here, हर किसी को पता है, most common site of cholestoma formation is Prusek space. But what is your INSA people, Central Institute, what they will be asking you, spread of cholestoma. But always remember from Prusek space, how this cholestoma spread. It spread via three important pathways. One is anterior pouch of Trollesh. One is anterior pouch of Trollesh. Better listen the question carefully. Listen the question. Better no need of writing in the chat box. Listen. Cholestoma from the middle ear, from the Prusek space. From Prusek space, it go in via anterior pouch of Trollesh, posterior pouch of Trollesh, and one is superior incidal space. Better these are, first I am teaching you the concept, then I will be asking you question. Superior incidal space, anterior pouch of Trollesh, posterior pouch of Trollesh. Now tell me, if there is a cholestoma in the Prusek space, it is going via anterior pouch of Trollesh, it is going into, yes, anybody, now question starts. Via anterior pouch of Trollesh, cholestoma is going into anterior epitympanum, anterior epitympanum. The first important questions in front of you. Expected MCQ for INICT examination, is your anterior epitympanum. Next is via posterior pouch of Trollesh. It is going into mesotympanum. Beta. Just remember, via posterior pouch of Trollesh, it is going into mesotympanum. Expected MCQs for upcoming INICT, mesotympanum, and via posterior pouch of Trollesh, it will be going into, yes, anybody, posterior epitympanum, posterior, superior incidal, slip of tongue, via superior incidal space, it is going into posterior epitympanum. 3 MCQs in front of you for upcoming INICT examination. Anterior pouch of Trollesh, anterior epitympanum. Posterior pouch of Trollesh, mesotympanum. Superior incidal space, posterior epitympanum. Are you getting the concept, beta? 3 MCQs in front of you. I am repeating again. I want you people should write in a nice way. Anterior pouch of Trollesh, anterior epitympanum. Posterior pouch of Trollesh, mesotympanum. Superior incidal space, posterior epitympanum. 3 expected MCQs on cholestoma. Most common site, Prusek space. In the last lecture where I have discussed all the anatomy of middle ear, I taught you 2 important points for upcoming NEET or INICT. One is Prusek space, most common site of cholestoma, and one is sinus tympani. What is importance of sinus tympani? Most common site for reoccurrence. So beta, if you are going for upcoming examination, just remember concept of sinus tympani. Anybody who can reply in the chat box? Sinus tympani is at the junction of which 2 walls? Is at the junction of medial wall and posterior wall. Medial wall and posterior wall. Medial wall and posterior wall. Now let us enter the next MCQ. I am giving a long history. Patient, 40-year-old male with a ear discharge, complaining of ear discharge since last 2 years, foul smelling, blood stain ear discharge. Patient, a typical history of, if I am mentioning the word foul smelling, blood stain, on examination there was a polypoidal mass, granulation, total perforation, all these going in the favor of anybody who can make a diagnosis. 5 words, 5 keywords given in the MCQ. 30-year-old male complaining of foul smelling, blood stain, ear discharge, on examination polypoidal mass, granulation seen. What is the diagnosis? Very good. Unsafe. Better nowadays we are not using the word safe, unsafe. Better to use the word attico-antral ear. Attico-antral ear. What will be the treatment of choice? Attico-antral. Sir, I will be going for mastoidectomy. Yes, I will be going for mastoidectomy. Which mastoidectomy we prefer? Always remember golden statement, canal wall down. Which canal wall down we are using? Modified radical mastoidectomy. So canal wall down, modified radical mastoidectomy. Any student who can tell me radical is indicated for, if most common surgery we people are doing is modified radical mastoidectomy, for that is one of the canal wall down procedure for unsafe ear. Can you tell me what is the indication of radical mastoidectomy? Beta, only one indication of radical. Anyone, any student in the chat box? Very nice response, beta. Everybody is trying. Yes, malignancy. Absolutely. Dr. Monga, Dr. Nandu, absolutely yes. Is Dr. Aman, it is malignancy. Very nice response. I am confident that you people have revised my notes more than 4 or 5 times. Everybody is replying nicely in the chat box. But this is the beauty of live sessions where we are interacting with you. We are just making you confident that you know everything. Beta, revise again and again, basic concepts. They will show you this image. I can make more than 5 MCQs on this slide. First of all, the examiner is telling this was an MCQ from your AIIMS 2017 where they have labeled external auditory canal. This is antrum. Now this is, if this is antrum, now label, and I can make more than 5 MCQs. The first question in front of you, if this is anterior wall, obviously this is anterior. Why this is anterior? Because this is external auditory canal. So this will be anterior wall of the mastoid. So sir, this is mastoid. Agreed. Everybody is confident this is mastoid. I have opened which wall? I have opened lateral wall of mastoid. If lateral wall, obviously we are in the cortex, so you are touching behind pinna, lateral wall. So behind, posterior. This is posterior. Agreed? Agreed. The first MCQ in front of you, the examiner will make a arrow at this point and he will be asking you, what is this area? The first MCQ. What is this slide? What is this segment? This is roof of the mastoid. Agreed. If this is roof of the mastoid, can you tell me some special term for the roof? Yes. In ear, whenever they are using the word for roof, always go for tegmen. So this is your tegmen of the mastoid. Tegmen of the mastoid. If this is the roof, very excellent, Dr. Anjali, absolutely yes. This is tegmen, roof. If this is the roof, what will be this area? Absolutely at the angle of 180. This area will be tip of mastoid. Okay. Now I am oriented. About basic orientation of this slide is in mind. But try to draw the line diagrams. But I always motivate my student. No need of mugging of the things. You just take this segment. From this area, I can teach you the whole anatomy of mastoid. Once I am confident this area is external auditory canal, the whole mastoid anatomy is cracked. This is external auditory canal. So this is posterior wall of the canal. Posterior wall of the canal, which is anterior wall of mastoid. Agreed? If this is anterior wall, at the angle of 180, there will be posterior wall. Yes, posterior wall. The second MCQ in front of you, if this is posterior wall, what is behind posterior wall? So behind posterior wall is a sigmoid sinus. So can I label it as sigmoid sinus? This is sinus plate. Absolutely yes. This is sigmoid sinus. And now tell me what is above roof. Above roof is your middle cranial fossa, dura mater. Can I label it as dural plate? Yes. So always remember, beta, roof of the mastoid is a dural plate. Posterior wall is a sinus plate. Examiner can ask you multiple MCQs. The first question, what is the angle? What is the angle, special angle between roof and the posterior wall? Can you comment on the name of this angle, beta? Very nice response coming in the chat box, beta. Everybody is responding. Please, beta, beauty of this lecture, please interact, live interaction. Yes. What is this angle known as? Sinodural angle. Special name, yes. Sitalis angle. Excellent, beta. This is Sitalis angle. If this is the tip of the mastoid, can you tell me some importance of the tip of the mastoid? Which cranial nerve is passing at this area? This is the tip of the mastoid. Which cranial nerve is moving at this level? Anybody? The next MCQ in front of you, this is your tip of the mastoid. Which cranial nerve is moving at this level? At this level is your seventh nerve. Seventh nerve. Can you tell me some importance of tip of the mastoid in a pediatric patient? A newborn come to you. What is the importance of the tip? Is the tip present in a newborn? Not at all. Tip develop at the age of 2 years. Yes, absolutely yes. What is the importance? Your NEET people will ask you 2 years. Beta, one-liner MCQs. Your INICT, they will ask you post-auricular incision. We never extend. Will you extend? Everybody should reply in the chat box. Will you extend the post-auricular incision in a newborn to the lower edge? Not at all. Why? Because if you will extend, you will cut the facial nerve. No, not at all. Everybody should be confident of this concept. Beta. Tip: facial nerve absent in newborn, therefore post-auricular incision should not be extended. If you are going for the upcoming NEET examination, beta, 3 incisions should be on your tips. One is your Wilde incision, WILDE''S. Wilde is a post-auricular, behind pinna. When you are giving incision behind pinna, is post-auricular. Beta, speed at which I am teaching you, I am asking you question, beta, this speed is the need of hour. Am I understandable? Just work 24/7 at this speed. Only the fast learner dominate in the game. Any game of your life, take my word, beta. If you are a fast learner, if you are going in a very fast mode, you will dominate. So just a very humble, friendly advice to all the students attending my session, beta. Play aggressively in upcoming days. Wilde, post-auricular incision, post-auricular incision. End oral, Lempert incision. What is Lempert incision? Lempert is end oral at the level of incisor terminalis, Lempert incision. And one is here along the annulus. What is along the annulus? Along the annulus we use a incision known as Rosen incision, R-O-S-E-N, Rosen incision. Lempert is your end oral. Clear? And Rosen. So 3 incisions should be on your tips. I am revising again. Wilde, post-auricular. Lempert, end oral, end oral. Lempert, what is the indication of Lempert? Pediatric patient. Whenever a pediatric patient comes to me, I always prefer Lempert because I can extend the external auditory canal. Rosen is for stapedectomy for otosclerosis. Dr. Anjali, excellent. For step otosclerosis, we are using Rosen incision. Coming to the next question for you. Yes, beta, what I am showing you, question number 6. This is something, a section of internal auditory canal. Internal auditory canal. Examiner is telling you facial nerve, superior vestibular nerve, inferior vestibular nerve, cochlear nerve. And they are asking you what is X and what is Y. What is this partition? What is this partition between facial nerve and superior vestibular nerve? Beta, what is X? Everybody, yes. The first reply, Dr. Gargi, excellent, is Bill's bar. What is Bill's bar? Bill's bar is a vertical partition between facial nerve and superior vestibular nerve. If examiner have asked you the Bill's bar, this was the AIIMS MCQ. They can even ask you what is the horizontal partition between superior vestibular nerve, inferior vestibular nerve. Any student who can comment, beta, what is partition between superior vestibular nerve, inferior vestibular nerve? Any student? What is this horizontal partition known as? If vertical is known as Bill's bar, what is horizontal known as? बेटा देखो ध्यान से, इसका नाम इसी में छुपा हुआ है, इसका नाम इसी में. Yes, anyone, any student who can tell me? Just wait. No. Just give me 1 second. This is this partition. I am talking about this partition, horizontal partition, this one, which separate your facial from cochlear nerve. Better slip of tongue. This area. This, what is this now? Facial from cochlear. This is your falciform crest. This now. So this facial nerve is well protected. I am again drawing the same image, beta. Just focus your eyes on the board. The horizontal partition. What is the horizontal partition known as? This is your Bill's bar. While this is known as transverse crest, is known as horizontal partition. This is horizontal partition. This vertical is known as Bill's bar. Very nice response coming in the chat box. Can you tell me the importance of Bill's bar and transverse crest? This horizontal partition is known as transverse crest. Can you tell me the importance of this area? What is the role of Bill's bar and transverse crest? Beta, it protect your facial nerve. This facial nerve is well protected. So is there any tumor, any mass? Very good, very nice, Dr. Mayuri. It is your protection of facial nerve. It protect the facial nerve. Dr. Shreya, excellent. It prevent facial nerve palsy. Coming on the next one. Very favorite, expected MCQ for the upcoming NEET examination. What examiner is showing you? 38-year-old gentleman having right-sided deafness for the past 2 years. On testing, 512 tuning fork, Remies and Weber finding are shown. Where this type of image can be given to you. Weber is lateralized to left side. What is the possibility? Now you tell me, beta, Very good. Dr. Nitin, you are telling my favorite statement. Write the possibility of Weber. Weber lateralized to left side. Everybody should tell me Weber lateralized to left side. Which are the two possibilities? Which are the two possibilities? Yes. Any student? Which can be possibility Weber lateralized to left side? Is your left conductive or right sensory neural deafness. Weber lateralized to left side. Right sensory neural deafness or left conductive. Agreed? Left conductive. Now you tell me what Rini's finding is telling you. Rini's finding is telling you the right side is your BC better than AC, means Rini is negative. Left side, your Rini is positive, is coming Rini is positive. Anybody, any student who can make a diagnosis of this patient? Any student who can make a diagnosis of this patient? Weber lateralized to left side. Weber lateralized to left side. While right side, the Renis is coming negative. Any student who can make a diagnosis of this patient? Excellent. This comes the right answer. It is false negative because your Weber Rini is finding mismatch. There is a lack of masking. Absolutely, Dr. Nitin. Excellent. This word I was expecting from you people. Here Weber is lateralized to left side. If it is lateralized to left side, there should be left conductive and right's normal, but on the right side we are appreciating it is bone conduction is dominating. It is false negative, so it is unilateral severe sensorineural deafness, so it will be going in the favor of B option. Excellent, beta. Are you getting my concept, beta? If Weber and Rini is finding mismatch, it means that there is some error on the behalf of examiner. Examiner have done a blunder. Which one? Yes, you people tell me. He forgot to do masking, and if there is a lack of masking, there will be false negative Renis. So this negative Renis which is coming on the right side is not true negative. If it would have been true negative, Weber should be lateralized to. You tell me, Weber should be lateralized to. Lack of masking, it should be lateralized to opposite ear, but air conduction should be dominated. If it would have been true negative, it should be Weber lateralized to right side. Why? Because in conductive deafness it is lateralized to ipsilateral ear. I am again explaining the same concept. We can crack this MCQ in different ways. One is you write the possibility of Weber and Renis and decide, and the second possibility, bone conduction better than ear conduction. Renis negative. If it is Renis negative, Weber should be coming to the same ear, ipsilateral ear. Right side is going to the left ear, is a false negative reading. So it is a right severe sensorineural deafness. So which are the four keywords for false negative Renis, beta? Is your severe unilateral sensorineural deafness, lack of masking, and one more point is there, transcranial transmission of sound. Because of transcranial transmission of sound is going to the opposite ear. So this will be a person. Now can we modify this MCQ? Let us change this question now. Everybody, Weber lateralized to left side, and they will be giving you some finding like this. Now tell me, if the examiner give you this type of finding, bone conduction better than air conduction, bone conduction better than air conduction, AC better than BC. Now what will be the right answer? Weber lateralized to left side, BC more than AC, that is expected. Left side, it means left conductive. And what is the finding of Renis? Renis should be negative. Yes, it is coming negative. So right answer will be left conductive. Now answer will be left conductive. So we will just try to attempt all the MCQs of these Renis and Weber, and the best way to crack is your write the possibility of Weber, and then you can rule out one by one. Clear? Coming to the next one, MCQ. Make a spot diagnosis. 50-year-old female comes to you with hearing loss. You advise the patient audiometry. Patient after pure tone audiogram. This is the finding on the pure tone audiometry. Can you make a spot diagnosis? Anyone? Any student? What is this? Is here Dr. Nitin only conductive deafness, or you can comment more than conductive deafness? Can you comment the side? Is right conductive or left conductive? Yes, very good. Dr. Nitin, airborne gap is seen to you. Airborne gap is there. Agreed. Airborne gap is there. Airborne gap is there, so it will be your conductive deafness. It will be right conductive deafness. Right conductive deafness. Agreed? Why presbycusis beta? Not presbycusis. If just concentrate beta, this is your conductive deafness. Presbycusis will be your sensory neural. If you just examine the downsloping graph, I got the point why you are telling me it is presbycusis, because you are appreciating the low frequency, high frequency hearing loss. But no, there is a airborne gap in the image, so it is going more in the favor of conductive deafness. And if it is conductive deafness, we should not comment on presbycusis. Now you people tell me, everybody, every student should reply, if this is conductive deafness because of airborne gap, can you tell me what is the minimum difference between the air conduction and bone conduction to label it as airborne gap? Anyone? What is the minimum difference between the AC and BC to label it as airborne gap? Absolutely excellent. Dr. Arshi, Dr. Shreya, it is not if 25, it is 15 decibel beta. Always remember, if there is a minimum difference of AC BC is 15 decibel, we label it as airborne gap. Difference of 15 decibel. Expected MCQ for upcoming NEET examination. Anyone? Spot diagnosis. I'm showing you one image. Yes, make a spot diagnosis. Any student? What is this one? Now, this is your maximum hearing loss at 4000 Hertz. Yes, any student? What I'm showing you? I'm showing you acoustic dip. Yes, I'm showing you acoustic dip. Can you tell me other's name? Very good, Dr. Anjali. It is Boiler's notch. Other name? Boiler's notch. What is the guideline? Any student who can tell me what is a guideline? WHO guideline. The first MCQ. Second, what is Indian Factory Act? What is WHO guideline? Acoustic dip, Boiler's notch. Everybody responding so nicely. I think ENT is one of your best topic. You can attempt all the MCQs of this subject. ENT, take my word beta, even 2-3 days back in FMGE, all the ENT MCQs were 20 MCQs from class notes. If you revise beta, these are short subjects, are rank scoring subjects beta. Radiology, ortho, ENT, take my word beta, if you revise them nicely, you can crack. The strike rate is more than 90%. Clear? So just focus on the short subjects in the last spell of your game beta. Short subjects, rank deciding subjects. WHO guideline 90. Yes, for 8 hours in a day, 5 days in a week, 5 days in a week. What is Indian Factory Act? Indian Factory, WHO is 85 or 90? Yes, slip of tongue. WHO, yes please beta. WHO is 85 or 90? Tell me. Anyone? Any student? We Indian people are lenient people. We are easygoing people beta. हम कहते हैं अगर 90 भी है तो कोई issue नहीं है. Why? Because we have very blind faith on God. We have good faith on God. We say 90 decibel is for Indian Factory Act. WHO is 85. But in your JIPMER examination 2019, they ask MCQ, what is the maximum limit? Listen carefully beta, this question can be repeated in your INICT examination. What is the maximum decibel limit in a city life? This word was given in your JIPMER examination. If they use the word city life, can you have 85 or 90 decibel in a city life in 24 hours? If you have 90 decibel, your ear will be permanently, they will be damaged. Excellent. It is 45 decibel. This is an old MCQ of JIPMER. In city life, day to day city life, maximum limit is 45 decibel beta. I have 3 MCQs expected on this topic. 85 decibel WHO guideline, 90 decibel Indian Factory Act. Indian Factory Act. And if they ask you something about city life, what is the maximum permissible limit is 45 decibel. बेटा इसमें से एक क्वेश्चन आएगा. Again, let us revise. If they give the dip at 2000, if they give a dip at 2000, I will make a Carhart notch. Carhart notch is seen in AC or BC. Let us crack this question now. Carhart notch, otosclerosis, pregnant female, conductive deafness, कारहाट नॉच, एयर कंडक्शन, बोन कंडक्शन। बेटा काम की बात याद रखो, बोन कंडक्शन आएगा क्वेश्चन, ये कहीं ना कहीं ये क्वेश्चन क्लिक करेगा। सो ऑटोस्क्लेरोसिस नॉट इन एयर कंडक्शन, कारहाट नॉच एक्सेप्शनली सीन इन बोन कंडक्शन, इट इज एक्सेप्शनली सीन इन बोन कंडक्शन। बेटा क्वेश्चन विल क्लिक, याद करेंगे। 4000 नॉइज इंड्यूस्ड ट्रॉमा, acoustic dip, boiler's notch. Which cells are damaged in noise-induced trauma? I show you this graph in NEET examination. I show you this graph. I ask you, beta, which hair cells are involved? Outer hair cell, inner hair cell. Noise-induced trauma or ototoxic drugs. Always, which hair cells are at high risk? Outer hair cell. If you are my student, beta, just remember outer hair cell. Outer hair cell most commonly damaged in noise trauma, yes. In ototoxicity, yes. Which cell are responsible for otoacoustic emission? Yes sir, outer hair cell. Very 3 important potential MCQ, answer to which is common, that is outer hair cell. Outer hair cell, clear? Otosclerosis, just remember this point, beta, bone conduction, कारहाट notch. King बाद में मरेगा, excellent बेटा. I am very happy that you remember all the analogy which I am teaching in my lectures. Yes, at end, yes. Next MCQ, coming to the, you must have revised the notes nicely. If you are replying all these points, beta, excellent. Last में king मरेगा. So your outer hair cell are the army. They are well smart people like Hrithik Roshan. Short Q-shaped body is your inner hair cell, very close to your axis of the cochlea. Very nice. What I'm showing you now. Now let us go in the INICT. बेटा चलो AIIMS segment में चलते हैं. What AIIMS people will ask you? No. Don't click on shorts. No. Don't jump on the short sign, beta. What I'm showing you red tympanic membrane. You are a DAMS student, beta. You are not here. You are not mugged up the things. We have taught you very nicely, and we are confident, beta. But the best motivation we people are getting these days is all the students who are appearing for their 3rd year prof examination, and all these students are getting distinction marks more than 75%. Take my word, beta. Why? Because last COVID, last 1 year, we all people, all the faculties, we worked 24/7, and we taught it so nicely. Even all challenges were there. Online platform was difficult for us, but we are very proud of the last efforts which we have done in the last 1 year, because of which all the students are giving such an awesome feedback these days, beta. They're getting nice distinction in their prof examination. Therefore, I always recommend my students gold standard class notes, revise beta. फालतू ना आजकल मल्टीपल सोर्सेज के पीछे मत भागो, जस्ट रिवाइज नाइसली ऑल दी गोल्ड स्टैंडर्ड क्लास नोट्स, और ऑल द रिजल्ट्स ऑफ द प्रॉफ एग्जामिनेशन दे हैव प्रूव्ड कि देयर इज नो शॉर्टकट टू सक्सेस बेटा, नो शॉर्टकट टू सक्सेस. वो जो स्टूडेंट्स दोज गो रन बिहाइंड फोटोकॉपी ऑफ द नोट्स, दे आर ऑलवेज इन अ कंफर्ट जोन के बेटा ठीक है जब मन करेगा पढ़ लेंगे. नो, नॉट एट ऑल. ऑलवेज बिलीव इन द लाइव लेक्चर्स वेयर वी हैव टू फॉलो द टाइम बाउंड गेम बेटा. एग्जामिनर कभी भी आके आपसे नहीं पूछेगा कि बेटा तैयारी होगी आपकी, एग्जाम ऑर्गेनाइज करें. नो, दे विल अनाउंस द डेट ओनली विदाउट योर परमिशन. एम आई अंडरस्टैंडेबल? सो वी हैव टू प्ले द टाइम बाउंड गेम. सो बेटा कंफर्ट जोन से बाहर आओ एंड लेट अस रिवाइज नाइसली. लास्ट फ्यू मंथ्स लेफ्ट बेटा, टेक माई वर्ड्स, रिवाइज नाइसली, रिवाइज ऑल दी notes nicely before your NEET examination, and take my word beta, you people will be getting good rank. Definitely you will be getting good rank. Now this slide, what I am showing you, I am sharing in between this experience because we are most of the students now, they always go for the shortcuts. They always feel कि ठीक है सर हम वो इतनी मेहनत क्यों करनी है बेटा, इतनी मेहनत नहीं करोगे तो 1-2 साल वेस्ट हो जाएंगे, तो इस बेटर अभी मेहनत कर लेते हैं. Am I understandable? Just this, follow this advice sincerely. No shortcut to success. We have to work hard. और हमने किया है बेटा. We people, I still remember 1 year back, we people were master of teaching in face-to-face lectures, and we were absolutely all the online lectures and online sessions were very new to us. But yes, हमने मेहनत की. We work 24/7 and we are seeing the results. Every student is comfortable. Clear? Now, coming back on this slide is a red tympanic membrane. I am a DAMS student. Red tympanic membrane को देखते ही मेरे माइंड में 3 पॉइंट्स क्लिक करते हैं. सर यहाँ तो ये ऑटोस्क्लेरोसिस का पेशेंट है. Either he is a patient of autosclerosis or he can, yes, acute suppurative otitis media. सर ने कार्टवील अपीयरेंस प्री सप्यूरेशन स्टेज में बताया था, ऐसा कुछ हमने याद किया था। और सर ये एक ग्लोमस ट्यूमर, या इट कैन बी ग्लोमस ट्यूमर, इट कैन बी ऑटोस्क्लेरोसिस, इट कैन बी ASOM। 3 MCQs in front of you. Pregnant female complaining of hearing loss. This slide given otosclerosis, and what is the slide label? We label it as show up sign, we label it as flamingo pink sign. Importance बेटा ऑपरेट नहीं करना, रेडनेस है, एक्टिव स्टेज है, we will not operate the patient. I will go for sodium fluoride. Am I understanding? ये तो एक MCQ क्वेश्चन मिलता है। दूसरा 30-year-old female with high grade fever, हाई ग्रेड फीवर, और ये स्लाइड साथ में आ गई तो हम समझ जाएंगे बेटा ये इन्फेक्शन की बात हो रही है। वी आर टॉकिंग, द एग्जामिनर इज टॉकिंग अबाउट सम इन्फेक्टेड etiology. So we'll go in the favor of ASOM, acute suppurative otitis media, but examination cartwheel appearance. Am I understandable? And if the examiner is giving some age 50-year-old female complaining of hearing loss, on examination bulging tympanic membrane, red bulging tympanic membrane, along with the bulging tympanic membrane, the examiner will give you, on applying the pressure on the tympanic membrane, there is a blanching that is known as brown sign. That is glomus tumor. Are you getting the concept, beta? So if this is a pregnant female, it will be otosclerosis. Is a high grade fever, is a ASOM. If it is a bulging tympanic membrane which blanches on pressure, is your glomus tumor. And if the blanching is there, what we call it as B for blanching, B for brown sign. Brown sign. Always remember this one. Expected MCQ for upcoming NEET. NEET वाले पूछेंगे brown sign या आपका rising sun sign. Am I understandable? And what your INICT people can ask you, yes, third level high है ना उनका, वो क्या पूछते हैं? Which artery you embolize before surgery of this patient? If this patient is a glomus tumor, if this patient is a brown sign, rising sun sign, which artery, important MCQ beta, which artery I will embolize before surgery, which is the feeder of this glomus tumor? Any student who can reply in the chat box, I'm waiting for a response. I'm trying my best to revise the whole otology in this given time, beta. Internal maxillary, Dr. Nidhi, I'm not talking about angiofibroma. No. Excellent. Here comes our right answer. Ascending pharyngeal artery. Ascending pharyngeal artery, beta. Excellent. Not internal maxillary. Internal maxillary IMA artery is for your angiofibroma, beta. Angiofibroma. Clear? Angiofibroma. It will be ascending pharyngeal artery. Ascending pharyngeal artery. Coming to the next one, what I am showing you, question number 11. 40-year-old male complaining of hearing loss. You send the patient to audiometry room. Audiologist gave you this report. What I am showing you, yes, a male coming to your ENT OPD with rising curve, Meniere's. Excellent. Female coming to your ENT OPD with Carhart notch is otosclerosis, is your Meniere's. What is the investigation of choice of the given tympanometry? This is an investigation of choice. Tympanometry? No. What will be the investigation of choice of this patient? Meniere's. What will be the investigation of choice, beta? Any student? I'm very happy, beta. All these ones are responding nicely. Electrocochleography. Electrocochleography is an investigation of choice. What is the treatment of this patient? Next MCQ. Treatment of this patient. Very nice response. Treatment क्या होगी बेटा? Meniere's. M for Meniere's. हमारे टीचर ने हमें सिखाया था M for Meniere's, M for male, M for medical treatment. Medical treatment. Can you reply? 90% of the patient respond by yes. 90% of the patient respond by dietary modification, low salt diet, dietary modification. 90% of the patient will respond. Clear? Surgery rarely indicated. What surgery we are doing? Big surgery, modified radical mastectomy? Not at all. Are you doing canal wall down? Not at all. What you will be doing? Are you doing any labyrinthectomy? Not at all. Which surgery we will be doing? Endolymphatic sac decompression. Endolymphatic sac decompression. Here comes the expected MCQ for upcoming NEET examination. Can you tell me which surgical landmark is used for endolymphatic sac decompression? I am showing you this image and I am giving you all the potential MCQs, expected MCQs. Yes, which surgical landmark is used for endolymphatic sac decompression? Excellent. Bush is Donaldson line. Very good. So, beta देखो next 1 minute. Focus your eyes on the board. Mean years. Male patient complaining of hearing loss, coming to you with tinnitus, vertigo, sensory deafness, and there will be fullness of ear. Fullness of ear. When these 4 points, again I'm repeating, tinnitus, vertigo, sensory deafness. In this order, patient coming to me, I'll be suspecting mean years, I'll be sending for PT, I'll be getting your rising curve, low frequency hearing loss. I will go for electrocochleography, then medical treatment. Patient not responding. In medical treatment, they can ask you positive pressure therapy. You should be confident which micro we are using. Positive pressure therapy, that is known as auditory physiotherapy. Auditory physiotherapy for mean-years patient. Clear? Patient not responding, we will inject gentamicin. What device we are using? Microwick we are using for injecting gentamicin near round window. These are the important points which you should remember for NEET examination. In INICT, they can ask you what is Lermois syndrome. Lermois syndrome is reverse of mean years. Reverse of mean years. Very good. Minute device. Reverse of mean years is Lermois syndrome. Then they can ask you Toulouse phenomena. Always remember golden statement. Sensory patient, any sensory patient, mean years, presbycusis, any sensory patient comes to you, there can be a recruitment phenomena. Because what is recruitment? Oversensitivity. And because of recruitment phenomena, patient always have oversensitivity, patient always have discomfort in noisy surrounding, that is known as Toulouse phenomena. T-U-L-I-O, Toulouse phenomena. So all these are expected MCQ, not rollover phenomena. But Dr. Nitin, rollover phenomena is dedicated to neural deafness. We are working in sensory deafness. Clear? So rollover phenomena is a hallmark feature of neural deafness. Recruitment phenomena is a hallmark feature of sensory deafness. I hope you people have revised the notes properly. Clear? Coming to the next one. Yeah, I have 5 questions on a single platform. I am showing you, first of all, tell me what I am showing you. Yes, any student, what I am showing you? I am showing you tympanograms. Yes, tympanometry is being done. I am showing you few graphs. Can you label what is A? If this is your normal graph A, so what is this one? Anybody? Tympanogram. Yes, we are working on tympanometry. Which graph is this one? This is, if this is A, if this is A, everybody should reply better. Big thanks to all the students who are taking efforts with me. Yes, tell me what is this one? This is which graph? AD graph. Excellent. This is AD graph. Now where is my arrow? What is this one? This was the last FMGE MCQ. What is this one? This graph seems to be flat. Yes. Is it flat tympanogram? Also some books even use the word B tympanogram or flat tympanogram. Yes. Is it flat tympanogram? B tympanogram. Now tell me what is this one? This is which graph? If yes, any student, which is this graph? Normal graph. They will label it normal. If this is normal, what is this one? This graph. This is not in the midline. Normal graph is in the midline. It is shifted from the midline. It is shifted on which axis? X-axis, beta. I can't afford teaching. I am going in the depth of this topic. But yes, if you have attended my lecture nicely, it is shifted on the x-axis. What is x-axis? X-axis is something to do with the pressure. Pressure, ET tube. C tympanogram, C tympanogram, C tympanogram. And what is this one? If this is normal, if this graph is normal, this graph, the blue color is coming somewhere on the lower height. On which axis? The y-axis. Y-axis is mobility, movement of the tympanic membrane. So this is hypo. So it will be otosclerosis. I did otosclerosis. Okay. Otosclerosis. Again, if this is your A, so this will be again AD. Again AD. Clear? So these are the important points as far as tympanometry is concerned. Anybody who can comment on the investigation shown to you. A 30-year-old female complaining of neurological symptoms, complaining of deafness. On pure tone audiometry, my audiologist say the patient is having conductive deafness. Okay. Anybody? Keyword given to you. Conductive deafness with neurological symptom, with a history of trauma 1 week back, with neurological symptoms, with conductive deafness on pure tone audiometry, I advise this investigation to the patient. Can you make a diagnosis? Before coming to the investigation, just comment on the diagnosis. This patient is suffering from, anyone, any student? This patient is suffering from neurological symptoms with conductive deafness, history of trauma. I'm sending the patient for some investigation where my technician is putting some electrode, one on the sternocleidomastoid mastoid, one on the external auditory canal. What I'm doing, this is VEMP, vestibular evoke myogenic potential. And what is the diagnosis of the patient? Superior semicircular canal dehiscence syndrome. Absolutely yes. Expected MCQ for INI-CT examination. नीट वाले नहीं पूछते, नीट वाले ना मीनियर्स और ऑटोस्कोपिक से रुक जाते हैं. इसके ऊपर INI-CT का गेम. सुपीरियर सेमिसर्कुलर कैनाल डेhiscence सिंड्रोम, VEMP इन्वेस्टिगेशन ऑफ चॉइस, VEMP वेस्टिबुलर इवोक मायोजेनिक पोटेंशियल सैक्यूल. इट इज इवैल्यूएट. नीट वाले ये पूछ सकते हैं आपसे, VEMP इवैल्यूएट, इट इवैल्यूएट विच पार्ट ऑफ द इनर ईयर? सैक्यूल ऑफ द इनर ईयर, सैक्यूल ऑफ द इनर ईयर. Worth remembering point, superior semicircular canal dehiscence syndrome. It is not sensory deafness, it is conductive deafness. So 2-3 बार आया हुआ है INI-CT में. They will ask you this question directly, indirectly. Is superior semicircular canal dehiscence syndrome is conductive deafness. Conductive deafness. Question number 14 and 15. What I'm showing you. I'm showing you 2 slides. Listen carefully, beta. Listen carefully. 40-year-old patient. दोनों की age 40 year. Both complaining of hearing loss. On examination, conductive deafness. Patient both have conductive deafness. Now you people tell me. Both patient age 40 years. 40 years. In both the patient, there was white debris. Listen carefully, beta. Listen keywords. I'm telling you the keywords. White debris in the external auditory canal. In both the patient, white debris in the external auditory canal. But in first patient there was no necrosis. But in the second patient, I was getting the evidence of necrosis. Can you make a diagnosis? What is X? What is Y? Anyone? 40-year-old patient complaining of hearing loss. On audiometry finding, conductive deafness. In the first patient, white debris without necrosis. Second patient, white debris with necrosis. Spot diagnosis. Excellent. Dr. Mayuri, beta, awesome. X is your keratosis obturans and Y is your cholestroma. So always remember, beta, in keratosis obturans is a growth abnormality. Now listen to the question. If I am your examiner, my question will be 40-year-old patient. Now listen carefully, beta. Listen carefully. 40-year-old patient complaining of hearing loss. On audiometry, conductive deafness was proved. On examination, otoscopic examination, there was a white debris in the external auditory canal without any evidence of necrosis. Diagnosis of keratosis obturans was made. Which of the given finding doesn't support the diagnosis? Which of the given finding is not in favor of keratosis obturans? Listen the MCQ. 40-year-old patient complaining of hearing loss. On audiometry, conductive deafness. Otoscopic examination, white debris with no evidence of necrosis. Diagnosis of keratosis obturans was made. Which of the given finding doesn't favor the diagnosis? Anyone? Any student? Excellent. Dr. Nitin, here comes the answer. It is age of the patient. Age of the patient 40. No. 40 is a young patient. 5 to 20 years. Why? You are a dense student with a growth abnormality. If it is a growth abnormality, how can it be at the age of 40 years? It will be 5 to 20 years. Age of distribution is 5 to 20. अब बेटा यहाँ से आके next level concepts. Listen carefully. This is what we see in 80% of the patients. 5 to 20 years is the age of presentation. It is bilateral because it is a growth abnormality. Agreed. But underline, if you are going for INI-CT examination and they ask you which of the following is a false statement, which of the following is a false statement, beta. Now you have to search false statement. Listen carefully. Which of the following is a false statement for keratosis obturans? For keratosis obturans, first statement. Example, I am taking you to the INI-CT beta. Listen carefully. First, it is seen in old age. It is seen in old age. First statement. Second statement, necrosis present. Necrosis present. Because this can be the question. This can be the aim of the best question which I'm sharing with you on this platform in this otology quiz is this one. Which of the following is a false statement regarding keratosis obturans? It is seen in old patient, or necrosis may be present. Necrosis may be present, which is a true statement. Anyone? Any student? Last 2 months in COVID era, we have seen the patient of keratosis obturans coming with necrosis. It may be present, beta. This point you have to add in your notes. Add in your notes, beta. Which is better statement, beta? One of the student, Dr. Parth Monga, is saying both are false. Agreed, both are false. But if you want to choose one, which is false, it is seen in old age. It is seen in young age, beta. But necrosis may be seen. We have seen in the last 2-3 months in COVID patients, keratosis obturans present with necrosis. Necrosis may be present, beta. Please highlight this point. Expected MCQ for upcoming INICT. Necrosis may be seen. In your all books, they have clearly mentioned necrosis is not a feature of keratosis obturans, but rarely it has been documented. Clear? So please, beta, you are going for Central Institute. They always give the new findings. So this can be the question. Diabetic patient, ईयर मैं डैम्स का स्टूडेंट हूं, मैं नेक्स्ट ऑफ दी लाइंस को नहीं पढ़ूंगा. डायबिटिक पेशेंट कमिंग टू मी विद ईयर सिम्टम, मैलिग्नेंट ओटाइटिस एक्सटर्ना. बेटा ऑलवेज रिमेंबर इन द लास्ट स्पेल व्हाट इज द नीड ऑफ आर. डायबिटिक पेशेंट, एमसीक्यू फ्रॉम नोज पे कुछ ब्लैक दिखाया, म्यूकोमाइकोसिस. एमसीक्यू ऑफ ईयर, डायबिटिक पेशेंट, मैलिग्नेंट ओटाइटिस एक्सटर्ना. एमसीक्यू ऑफ ओरल कैविटी सोचना नहीं है, इज अ लुडविग एब्सेस. बेटा इसको कहते हैं, वी हैव रिवाइज द नोट्स मोर देन 5 times. ईच एवरीथिंग ऑन योर टिप्स. ईएनटी में डायबिटिक वर्ड, बेटा 3 पॉइंट्स के अलावा चौथा पॉइंट नहीं होगा. टेक माई वर्ड्स फॉर योर एमसीक्यू. और एग्जामिनर कैन शो यू दिस स्लाइड. देयर इज pus coming from the external auditory canal. There is a blackish mass in the external auditory canal. Diabetic patient, I will be going for. Which are the important words? Just remember. Malignant otitis externa, also known as osteomyelitis of skull base. बेटा 1 मिनट में पूरे टॉपिक को रिवाइज करेंगे. Everybody focus your eyes on the board. Diabetic patient, ear discharge, granulation, polypodal mass in the external auditory canal. Tympanic membrane seems to be normal, but what is important finding? Facial nerve palsy. Patient मेरे पास ओपीडी में आएगा. 2 इन्वेस्टिगेशन करेंगे. कौन सी? टेक्नीशियम 99 एंड गैलियम. टेक्नीशियम करते हैं हम डायग्नोसिस के लिए, गैलियम प्रोग्नोसिस के लिए. बट इन मेडिकल कॉलेज पेशेंट इज वेरी पुअर, सो ही कांट अफोर्ड टेक्नीशियम, गैलियम. मैं क्या करूंगा? आई विल गो फॉर ESR. ESR after how many weeks will come down? 2 weeks. Potential MCQ. Which bacteria are Pseudomonas? Which drug of choice? Third generation cephalosporin. Sir, not in the option. I will go for penicillin. Not in the option. I will go for ciproflox. Which surgery I can do? Debridement of the granulation tissue. These are 9 not 10 MCQs. Again, I am repeating. Diabetic patient, granulation, polypodal mass, facial palsy, ear discharge, technician 99, gallium scan, ESR 2 weeks, Pseudomonas, cephalosporin not given, penicillin not given, ciproflox, debridement. इसके अलावा बेटा कोई क्वेश्चन बनता नहीं. अब लास्ट के 1-2 महीनों में अगर आप इफ यू आर स्पेंडिंग हाफ एन आवर 1 hour on malignant otitis externa, बेटा don't waste your time in going for the examination. In the last spell, हमें 1 मिनट में टॉपिक को कंप्लीट करना. I'm confident you people are getting the main message behind this quiz. We have to run at the speed of bullet train. बेटा स्पीड पे भागना है. इस टाइम पे हम टॉपिक की डेप्थ में जाएंगे, हम रैंक को लूज करेंगे. टेक माई वर्ड, वी आर ऑल आर ऑन द बॉर्डर लाइन. इसके बाद आफ्टर दिस नीट देयर मे बी पॉसिबिलिटी ऑफ नेक्स्ट एग्जामिनेशन, देयर मे बी पॉसिबिलिटी ऑफ न्यू पैटर्न. सो इट इज बेटर वी शुड क्रैक एज सुन एज पॉसिबल. बेटा हमने जो ये नीट है, इस लास्ट नीट है, अपने एक रूम में आपने बिग कैपिटल लेटर्स में लिखो, इस नीट के बाद मैं एग्जाम नहीं दूंगा, मुझे इसको क्रैक करना है एट एनी कॉस्ट. 24/7 डू revision. Am I understandable? Are you getting my message? We have to run in a very fast mode. Clear? Yes, let us crack few queries. Few students are asking. Repeat the antibiotics. Antibiotics with a third generation cephalosporin not mentioned, go for penicillin. Not mentioned, go for ciproflox. This is the order. Third generation cephalosporin, penicillin, ciproflox. Debridement is a surgery. Debridement of the granulation tissue. Coming on the next one. Now what is this? हाँ जी, ये क्या है? 25-year-old male with a history of SLAP. 25-year-old male with a history of SLAP and tympanic membrane. Examiner is showing you a perforation on the tympanic membrane with the history of trauma, traumatic perforation. What is the treatment? Capital letter, wait and watch. With keep the ear dry. Just remember, what is the treatment? You tell me. Traumatic perforation with the history of trauma. Trauma is there. Trauma, perforation on the tympanic membrane, wait and watch, keep the ear dry. Beta kitne mahine? 3 months. Remember, within 3 months, the tympanic membrane will heal of its own. For the last 5 years, I am observing your PGI people in the INICT now. They can give you this question, beta. They will give you choices. And choices will be nice choices. Topical antibiotics should be used to avoid secondary infection. Not at all. Go for dry, dry, dry. Keep the ear dry. This tympanic membrane will heal within next 3 months. Clear? Anybody who can tell me 3 months, importance of 3 months? कहाँ पे आता है question और जिसमें answer 3 months होता है? Anybody? Tympanic membrane का MCQ है. Year का question है. MCQ of tympanic membrane. Answer is 3 months. Yes, what I am talking about? I am talking about grommet. Grommet is inserted after how many months of treatment failure? 3 months of treatment failure. Dr. Anjali Verma, excellent, is a grommet. The first answer coming from Dr. Anjali is grommet after 3 months. Clear? Question number 18. Yes, इसको crack करते हैं. 12-year-old child, right side, mucopurulent otorrhea, ear discharge for the last 5 years. A week ago, he became dizzy with nausea, vomiting, nystagmus to the opposite side. First of all, make the diagnosis. Long-standing ear discharge. What is long-standing ear? Let us go one by one. What is long-standing ear discharge? Make a diagnosis. Yes, but a patient is actico-antral. Actico-antral. Clear? Now the patient is having vomiting, nystagmus to the opposite side. It means your inner ear is involved. Labyrinthitis. So can I label the patient actico-antral with labyrinthitis? Yes. Or simplified word, complicated actico-antral patient. Complicated actico-antral. First of all, tell me what is the diagnosis? What is the treatment of this patient? Yes, anyone? What will be the treatment of this patient? You will be going for canal wall down or canal wall up mastoidectomy. Actico-antral with labyrinthitis here. Inner ear symptoms are coming. So I will be going for canal wall down. Canal wall down. Which canal wall down we people are doing? Remember this concept. Clinically, we always do modified radical mastoidectomy, MRM. If the examiner asks you, what we do commonly done surgery is MRM, modified radical mastoidectomy. Now the examiner is giving you, after 3 days, the patient is irritable and the severe headache is there. Patient also have neck retraction. What I am talking about? Neck retraction with severe headache, when a patient is having labyrinthitis, it means the complication from intratemporal is going into intracranial patient, which is the most common intracranial complication. Meningitis. Absolutely excellent. But a nice response coming. I don't know, few books, few faculties, they are teaching brain abscess is the most common. Not at all. It is meningitis most common, brain abscess is second most common, which brain lobe is involved, temporal lobe is involved. Most common complication overall, if the examiner asks you most common complication overall, it will be mastoiditis. Most common extracranial is mastoiditis. Clear? Then you should be confident of all the lateral sinus thrombosis, one of the rare complication, but important MCQs are there. You should be confident of all these signs. But in upcoming NEET examination, they will be asking you one MCQ on lateral sinus thrombosis, because this is a potential topic. This is a must-read topic जो हमने पढ़ना है बेटा. So all the important signs which we see, spiky fever, or your delta sign, anti-delta sign, or Graysinger sign, Kovac sign, all these findings of lateral sinus thrombosis should be on your tips. Again, I am repeating, most common complication is mastoiditis. Most common extracranial mastoiditis. Most common intracranial meningitis. Clear? Coming on the next one, I am showing you. Can you make a spot diagnosis? Yeah, 10-year-old child coming to you. Tympanic membrane appears to be normal, is moving inside. I feel I'm getting some impression of the ossicles, and tympanic membrane is not showing any cone of light. No handle is visible. Absolutely yes. Dr. Kashyap is a retracted tympanic membrane. So first of all, the MCQ go in the direction of retracted tympanic membrane. Now, what is the next MCQ I can format for you? Retraction is seen in the part flaccida as well as retraction is seen in the part tensa. Now the next question is, which classification will be used for retraction of the tympanic membrane in the upper part? If I want to show the retraction in the upper part, Which classification is used for this area? Par flaccida. Which classification we are using? We are using TOS classification. TOSS, TOS classification. So always remember, TOS classification is for par flaccida, TOS classification, TOSS. And for tensor, which classification we are using? Sade classification. Anyone who can comment on grade 1, grade 2, grade 3 and grade 4? Yes, expected MCQ for upcoming examination. TOS classification. Par flaccida, grade 1. What is grade 1? You tell me. Grade 1, retracted but not touching malleus, is not touching malleus, not touching malleus. Grade 2 will be touching malleus. Grade 1 not touching malleus. Grade 2 touching malleus. What will be grade 3? Grade 3 will be mild apitympanum, mild damage to apitympanum. What will be grade 4? Grade 4 will be severe damage to apitympanum. Grade 4 will be severe damage to apitympanum. Severe damage to apitympanum. What is Sade classification? Grade 1, grade 2, grade 3, grade 4. Part tensor, retracted but not touching incus. Grade 2 will be touching incus. Yes. Grade 3 will be touching medial wall, promontory, medial wall, but is mobile. What is grade 4? Is here adherent to promontory. Always remember, it is adhesive ear. In grade 3, I label as atelectasis of ear. This is a potential MCQ. Atelectasis of ear. Grade 4 is your adhesive ear. Adhesive ear. TOS classification and Sade classification is very important for upcoming exam. Either they can ask you in INICT or they need. This is one of the important classification. Clear? Comfortable with this one? Now, in your MCQ, if the examiner is showing you a pathology in this area, अब ध्यान से देखेंगे, if the pathology is in this area, what will be the treatment? What will be the treatment of a pathology in the X area, in the Y? Yes, anybody? If there is a pathology in the X segment, we will be going for modified radical mastodectomy because it will be attico-antral. Why? Because keyword par flaccida is involved. If your par flaccida is involved, I will be going for MRM. And if there is a pathology in the lower segment, Y segment, I will be going for tympanoplasty. Tympanoplasty with OCR, ossicular chain reconstruction. Ossicular chain reconstruction. So they can format an MCQ in this way. They can show you a tympanic membrane, upper part, lower part, and they can ask you either where you will be going for modified radical mastectomy or tympanoplasty with OCR. Now listen carefully. On this platform, let us crack. 4 options are always there. There are always 4 options are there. Now listen carefully. 4 options always there in your MCQs. The first option, there is a bulging tympanic membrane. There is a bulging tympanic membrane with high grade fever. So I will be going for AS1. If there is no fever, no congestion, I will be making it as sinusitis media. If it is sinusitis media, I will be going for grommet. Maryngotomy where sinusitis media anterior-inferior with grommet. But if there is AS1, I will be going for circumferential incision where posterior after giving your antibiotics. Now, the third option will be, one option is your maryngotomy, second is your grommet insertion, third will be tympanoplasty, fourth will be MRM. So always remember, bulging tympanic membrane, no fever, no congestion. It is sinusitis media. I will be going for grommet. That is your glue ear. If there is a high grade fever, congestion, cartwheel appearance, I will be going for AS1. Followed by, if there is a perforation in the lower part, that is your tubotympanic ear, we go for tympanoplasty with ossicular chain reconstruction. And if there is an upper area involved, I am giving you few keywords. Focus on a keyword in INICT. If the examiner give you any of this word, foul smelling, blood stain, granulation, polyp, attic, editors, antrum, par flaccida. If out of these words any word is mentioned, go for MRM, modified radical mastectomy. I hope you are getting my message clear. So just revise in this nice way. Clear? Everybody comfortable? On the other side, these are the 4 possibilities. They can ask you the MCQ, they can raise a question. Clear? Coming on the last MCQ, last expected question. Question number 20 in front of you. Make a diagnosis. What I am showing you. I'm showing you some CT examination of your cochlea. I'm showing you CT examination of cochlea. Any student who can make a diagnosis? What I'm showing you a cochlea, and surrounded by cochlea, there is again one ring is there. What is the aim of this slide? Just give me 1 minute. Very nice response coming in the chat box, beta. Either examiner will show you this slide or this slide. Now, if examiner show you this slide instead of 2.75, if examiner is showing you 1.5 ton, तो बेटा ये तो हो गया मॉन्डनी डिस्प्लेसिया. इसको कंफ्यूज मत करना, मैं फिर ड्रॉ कर रहा हूं आपके लिए. जस्ट फोकस योर आइज ऑन द बोर्ड. If instead of this image, if the examiner is showing you this image, it is 1.5, it is Mondini. What is the importance of Mondini dysplasia? Most common indication of cochlear implant. ठीक है सर, ये बात तो बिल्कुल समझ में आती है. But instead of this, if examiner is showing you a image in which there is one ring of cochlea surrounded by a second ring of cochlea, this is double ring sign for cochlear autosclerosis. Very nice response. Cochlear autosclerosis. Last question of the day. Can you tell me what will be the audiometry finding in this given slide? What will be the audiometry finding? A student who is genuinely preparing for INICT examination. Excellent. Here comes Dr. Partha. Excellent, beta. Proud of you. Very nice. Which will be the audiometry finding of the given slide? Dr. Nitin, excellent. Dr. Varkha, excellent. It is cookie bite audiogram. Cookie bite audiogram. What is cookie bite audiogram? On PTA, you will be getting a W-shaped graph. You are getting a W-shaped graph. That is cookie bite audiogram for cochlear. So, autosclerosis, commonly it is at the level of foot plate. Fistula antifenestrum, it is somewhere at the anterior part of oval window. But if it is in the cochlea, we will be having double ring sign or cookie bite. These are the two important findings of rare variety of cochlear autosclerosis. Am understandable? Autosclerosis, 1 MCQ will be there. Clear? This is Mondini dysplasia, most common indication of cochlear implant. What is the lowest age of cochlear implant? Anybody? What is the lowest age where we can use cochlear implant? Let us crack all the controversial points for upcoming INICT examination. Yes? Anyone? What is the lowest age for cochlear implant? Is 6 months or 1 year? 1 year. 6 months is the right answer to which MCQ in the contest of cochlear implant? 6 months is the right answer to which MCQ in contest of cochlear implant? Anybody? Any student who can reply in the chat box? 6 months is the right answer to which MCQ in contest of cochlear implant? Anyone? Any student? 6 months is the right answer to which MCQ? Any student? No, better. No. 6 months? No, not screening. Screening answer is OAE, acoustic emission, should be done on first day, should be definitely done by first month. Child should be, if any newborn congenital deafness is there, the child should be corrected. Absolutely. Dr. Vani, excellent. A congenital deafness should be treated by 6 months to avoid any mal development in language. If you want this child should not have any mal development in language, you should treat the child by 6 months. Am I understandable? Are you getting this point? So 6 months is the child. I want to share 2 more MCQs with you. Auto-acoustic emission is a screening procedure of choice in a newborn. In congenital deafness, we always prefer OAE with BARA. So if they ask you the first one, we use OAE. But if the examiner use a high-risk baby, if the examiner mention the word high-risk baby, they can give you a long history. The newborn is admitted in ICU, suffering from meningitis. So in that scenario, the screening procedure of choice will be BARA. Screening choice will be BARA. Am I understandable? Are you getting this point? Dr. Amar Kumar, yes. Traumatic tympanic membrane perforation will be treated by tympanoplasty, obviously. But if there is a history of trauma, if the patient give you a history of traumatic perforation, it always heal of its own. clear. So this complete here all the important MCQs. I touch all the topics. I tried my best beta just to revise in a fast mode. और एक बात याद रखो बेटा, nobody can defeat you except your mindset. Always remember बेटा, अगले कुछ दिनों में हमने 24 घंटे मेहनत करनी है. हमने एक बात को सोचना है कि ये लास्ट नीट एग्जामिनेशन. इस नीट के बाद पैटर्न चेंज होगा, काफी चेंजेस आएंगे. इट विल बी वेरी डिफिकल्ट फॉर मी टू अडेप्ट टू द न्यू चेंजेस इन द गिवन टाइम स्लॉट. इट इज बेटर जो है हमने इस नीट को क्रैक करना है एट एनी कॉस्ट. एम आई अंडरस्टैंडेबल? आर गेटिंग दिस पॉइंट? एग्जाम इज गेटिंग डिलेड. दोज थिंग्स विच आर नॉट इन माई कंट्रोल, डोंट वेस्ट योर टाइम बेटा. उस चीज पे हम टाइम वेस्ट नहीं करेंगे जो हमारे हाथ में नहीं है. एम आई अंडरस्टैंडेबल? डोंट वेस्ट योर टाइम on social media. Just try your best to take the academic advantage of Facebook exclusive club, DAMS exclusive club. Next few days में बेटा we people are with you, वो DAMS faculties are with you, and we promise you we will leave you till the gate of post graduation college. हम आपको वहां तक छोड़ के आएंगे बेटा. But have blind faith, revise the class notes. Don't waste your time in unwanted things, multiple sources giving multiple you can say stuff to you free of cost. Not, it is not free of cost. Your time is very valuable. Last 2-3 months में बेटा कोई एक्सपेरिमेंट मत करना गलती से. आप डैम्स के स्टूडेंट हो, डैम्स के नोट्स को रिवाइज किया आपने, जस्ट रिवाइज अगेन एंड अगेन, एंड वी प्रॉमिस यू you will get a good rank. You crack with flying colors. Thanks a lot all the doctors on this platform. I wish you very best of luck, and I promise you beta okay, yes, you people, dedicated Amsonians, will be definitely getting awesome rank in upcoming days, and prepare hard. Last message which I want to share with you, go for INICT very sincerely बेटा. मैंने कई बच्चों को देखा है वो तो ऑलवेज फील कि ठीक है सर देख लेते हैं, कोशिश करते हैं, क्रैक करते हैं, हो जाएगा तो वेल एंड गुड, अदरवाइज विल गो फॉर नीट. नहीं है ऐसा कुछ भी नहीं. टेक माई वर्ड, इट इज वेरी इजी टू क्रैक INICT if you apply your common sense. There is never have this type of impression कि बेटा only AIIMS students or JIPMER students they will be getting rank in INICT. Not at all. Last 2-year experience, peripheral colleges, they are getting very awesome rank in the INICT. So I will just motivate my all the students. अपने mind setup ये नहीं रखना कि I am from a peripheral college, I am from a private college, I cannot crack INICT. You people can crack better. We have many students who got rank in top 10 this year. So very best wishes. We stop at this point better. Thanks a lot for listening to me.